having a few more come in, but we'll just get started. So just a little bit about bite medicine, which I'm sure many of you do know about. Got a great question bank, great topics as well. I think they've got 600 topics at the moment, so definitely go through them all. And they've got a new feature where you can amend notes as you go through them, so you don't have to stick to just their notes. You can add other things too. So that's that. So we're going to get on to Croup. Sorry, I just realized I put bronchiolitis there, but that's on the previous one. So we're going to understand the pathophysiology, risk factors and features of Croup and recognize a classification criteria. And then we're going to understand the investigations and the management. And as I said, I've scattered some SBAs, some questions throughout the session as well. So just write in your answers or any questions that you might have along the way in the Q&A tab. And I can, as I said, I can see them even though you might not be able to see other people's questions and answers. So please do come forward. So we'll go straight into it with a question. So there's a 3-year-old who's brought into ED by her mum. She's coryzal, so quite snotty, very much like me, for the last few days, and has developed a harsh cough. So on examination, you notice intercostal recessions and some occasional stridor. So stridor being that inspiratory wheeze where you hear that with the blockage in the breathing. So that's what you hear on examination. So bearing in mind what we're talking about, what's the most likely causative organism? So I'll give you guys maybe like 10-15 seconds. So feel free to write, as I said, in the Q&A tab. I can see your answers, and then we'll move on to the answers from there. Lovely. Yep, I see your answers coming through. So that definitely works. Cool. So yes, correct. The answer is parainfluenza. So we'll go through the pathophysiology and then we'll go back to those answers and see which one's common for which. So Croup, also known as laryngotracheobronchitis, and it's a mouthful, so that's why it's shortened to Croup, but basically what that full name is what essentially goes on. So it's a viral upper respiratory tract infection, most commonly caused by parainfluenza, and it affects around 15% of children at some point in their lives. The rarer causes, but still causes, include RSV, influenza, adenovirus, and bacterial Croup. So laryngeal diphtheria, for example, but they're a lot less common when it comes to bacterial Croup. So how it happens is you have the exposure to the pathogen, so it enters through the respiratory way, through droplets, and then there's migration and infiltration of white blood cells within the upper respiratory tract. So again, all in that upper respiratory tract area. And then that results in inflammation and swelling of the larynx, the trachea, and the large bronchi. And that essentially is Croup. So just going back to our questions, with RSV, as we kind of went through in our previous seminar, so that's the most causative organism for bronchiolitis, and it's mainly children under 1 year, and they shouldn't be having a stridor. That's when you're kind of particularly concerned if they're bronchiolitic and have stridor. So influenza, there is the case, but not as much as parainfluenza. Norovirus typically causes gastroenteritis, and strep pneumonia causes pneumonia and meningitis. So in pneumonia, you'd tend to see more high fevers, a productive cough, and focal crackles as well, and auscultation, but you wouldn't really expect a stridor. So on to our next question. Which of the following is not a risk factor for developing Croup? And we've got age 7 to 10 years, male sex, prematurity, presentation during winter, or an underlying respiratory disease. I think we had a few extras coming as well, so feel free to answer the questions in the Q&A tab because the chat is disabled, but I can still see your answers, so yeah, go ahead. I'll give you 10 seconds and then I'll move on to the answers. And this is which of the following is not a risk factor for developing Croup? Cool, correct. It's age 7 to 10 years. So when it comes to risk factor for croup, its age is a risk factor, but it's not the 7 to 10 years. It's 6 months to 3 years, so a lot younger. Male gender is a risk factor as well. Presentation in late autumn to winter, so very much this period of time at the moment. And prematurity, and that's in particular if they have a chronic lung disease with prematurity as well. And of course, underlying respiratory disease. So clinical features, I think the one that's typically associated with croup that everybody knows about, and that parents will even come in telling you, saying that, you know, they've heard this barking cough throughout the night, is the barking cough. It's a very seal-like kind of noise. I don't have a sound for you, but you can literally play it on YouTube, and it's a very distinct cough that presents with croup. There's difficulty in breathing as well, and there's coryza, so sore throat, runny nose, blocked nose, you know, a bit of ear pain, so all those coryzal symptoms. With the signs, what you might see with the patient in front of you, they might have a temperature. They might have stridor, and that is that inspiratory wheeze. It's that inspiratory sound that you'll hear, not really a wheeze, to be honest. It's more airway related, but you tend to hear it inspiratory wise. And then there's the respiratory distress. So you might see intercostal and subcostal recession. So that's kind of in between the ribs and just below the diaphragm. Tracheal tug, so just there, or they also call them suprasternal recessions. Nasal flaring, accessory muscle use, so kind of there, and then head bobbing as well. So which of the following radiographic features is in keeping with croup? So what might you see on a chest x-ray or a neck x-ray if you were to do an x-ray with someone with croup? So again, question and answer in the Q&A tab, if that's okay, and I can see them. So yeah, I'll just give you 10 seconds. I'll just count it down in my head and then we'll move on to the answers. Give you 5 more seconds. Yep, correct. It's steeple sign. So just going through the other one, so church sign isn't a sign. Thumb signs, that's something that you would see in epiglottitis in a neck x-ray. Sales signs, this you can see in quite a few areas of chest x-rays, but for example, it's a left lower lobe collapse you might see. The deep sulcus sign, so it describes a deep costophrenic angle, and it can be to do with a pneumothorax on a supine radiograph. And in steeple sign is what you would typically see in croup if you choose to do an x-ray, but you don't usually. And that is basically due to tracheal narrowing. So this is essentially what steeple sign is. So it's how, when you see a steeple in a church, basically, and it's how it's narrowed there, and that's because of the tracheal narrowing. And then just to show, it's a common exam question in terms of differentiating between the two. Thumb sign with epiglottitis, so you can very clearly see how it is there, where it just protrudes a bit further outwards when it's epiglottitis. So investigations, as we mentioned, it's very much a clinical diagnosis. The features described by the parent or what you see in front of you will very much make you go, yes, this is croup. So you wouldn't tend to do much imaging unless you're concerned about something else. So what you could do is an x-ray, and as we saw, you'd see that typical steeple sign. But in general, because it's clinical diagnosis and investigations involve cooperation from children, which they won't necessarily do, especially when they're upset. You don't want to upset them further when there's that risk of airway compromise. So you kind of treat it and you see it based on a clinical diagnosis. I already gave away the answer. So which of the following clinical features alone are most in keeping with severe croup? So this is clinical features alone. So if you didn't see the answers, or if you saw the answers, it's fine. So just remember severe croup, and bearing in mind that croup does have a classification criteria. So would you see stridor at rest, intercostal recessions, lethargy, barking cough, or a tracheal tug? And we're talking about clinical features that is in keeping with severe croup. So feel free to write your answers in the Q&A chat. Let's give you a few more seconds. This is a bit of a trickier question. I'll give you 5 more seconds just because we've got a few more answers coming in. Cool. So it's lethargy. So stride or at rest. So we will go through this classification criteria in a second, but stride or at rest is a sign of moderate croup. Intercostal recessions, a sign of respiratory distress, but still a sign of moderate croup. When it comes to lethargy, so with severe croup, it tends to be respiratory distress, and stride or at rest can also be a part of severe croup, but usually if that is in keeping with lethargy as well, so it would be associated with lethargy too. So lethargy is the thing that differentiates it and puts it into severe croup from moderate croup. So barking cough, as none of you guessed, so that's mild croup, correct? You'd hear it anyway. And a tracheal tug, again, a sign of respiratory distress, like intercostal recessions, is a feature of moderate croup. So just to go through, so this is the Wesley classification. So it is the scoring system for croup. It's something that sometimes is used in practice. I think some trusts, like the trust that I work at, it's a modified version of this. It's slightly shortened. But typically there's always going to be a classification system for croup. So you can categorize it into mild, moderate, or severe, or pending respiratory failure as well. So I think when it comes to learning about the scoring system, I'd say it is memorizing things. There's a lot to look at in this table, but I think knowing that you've got the Wesley classification and just roughly knowing what goes into mild, moderate, and severe is in general enough, as opposed to kind of knowing exactly like strict like number criteria. It depends how you learn, but that's kind of how I learned. It was more to do with what goes into mild, what goes into moderate, what goes into severe, rather than remembering the marks for each one. So with the Wesley classification, so looking at chest wall retractions or those recessions that you might see, it's basically like respiratory distress is essentially how you'd interpret that one. So if there's none, it's 0. Mild, you might just see with a nasal flare, but when you've got the tracheal tug, intercostal, subcostal recessions, that's when it would go into moderate. But if you're using all of your accessory muscles, then like as a combination, it would give you to 3 marks. Inspiratory stridor, so as we saw, so with agitation will give you a mark, but that can be with that can be with mild croup. It's when it's at rest, puts you into moderate. And cyanosis and consciousness, so that's kind of quite far into the severity of it, so it gives you 4 or 5 marks. And then air entry, basically on auscultation, they can be reduced or it can be markedly reduced because those bronchi are so inflamed that it's, you're not getting air to all the lung, and that's how you would categorize it. So but when you look at NICE guidelines, it's kind of how this is kind of how I would remember it easier, I'd say. So mild, as we said, puts you with that occasional barking cough, no stride or suprasternal, or those tracheal targeted intercostal recessions, so no real signs of the respiratory distress, and the child is generally happy even if they have this barking cough. And then moderate, you might see that, oh yes, and with the no stridor as well, you might see stridor on occasion, on exertion, but that would still put them at mild. So it's more like how they are at rest that we're looking at. So moderate, you might see this barking cough with this audible stridor at rest. So those are all things that put it into moderate. And then the suprasternal intercostal recessions as well puts it into moderate when it's at rest. And then, but at this point, again, the child can be consoled, they can be calmed down, they're not particularly agitated or lethargic. Severe is when you're having this frequent barking cough and you've got kind of all your accessory muscles used with this respiratory distress, as well as agitation and lethargy, and you have this inspiratory stridor with or without this expiratory stridor as well at rest. So there's you can see how we're getting worse and worse. And then impending respiratory failure is very much kind of, as we saw in the previous slide, like decreased level of consciousness, fatigue, pallor, cyanosis, and you've kind of got this increasing upper airway obstruction. The child just does not look right. Just, you can see it's not going in the right direction. So yes, that's when it comes to with the NICE classification. So it's a bit more, it's not very like numerical as such, it's more just based on what you see. So on to our next question. So Dad brings his oh, by the way, any questions throughout, just feel free to ask them in the Q&A tab, because as I said, I can see them, so ask away. So question 5, Dad brings in a 2-year-old son to ED, has an audible barking cough, and Dad mentions that he's had some difficulty breathing overnight and noted he was sucking in his ribs, so probably those like intercostal, subcostal recessions. So on examination, you notice that the child has stridor when he's running around, so on exertion, and that there are no visible intercostal, subcostal recessions currently. So it seems like he's gotten a bit better than what he was overnight. Observations are as follows. So oxygen 96%, temperature 38.3, heart rate 140, respirate 40 as well. So which of the following is the correct management option? So would you discharge home with dexamethasone? Would you admit and give dexamethasone? Would you give nebulized adrenaline, nebulized budesonide, or would you intubate the child? So feel free to answer. I'll give you a few more seconds for some final answers. They're getting a bit of a mix, which is good. Cool. Okay, so the answer is discharge home with dexamethasone. And why? So here, looking at everything, the child has mild croup. So he has this occasional barking cough. There is stridor on exertion, not at rest. So we're happy that it goes under the mild category. And so for mild croup, you treat with a stat dexamethasone dose, and that's just an oral dose, and you discharge home with safety netting. You would admit if they've got anything above mild, so if they've got moderate or severe or kind of like impending respiratory failure, you're going to admit them. If with nebulized adrenaline, it's mainly in an emergency, so it's more with that if you're sensing that the airway obstruction is imminent, because that causes that temporary opening of the airways until you have time to kind of intubate the child. So it's used when the child is very, very unwell and we're heading in that direction. Nebulized budesonide, so that's the second line from dexamethasone. So if the dexamethasone isn't tolerated, or if the child isn't able to tolerate oral fluids or anything, then we'd go with nebulized budesonide. And then last resort is intubation, and that's, as I said, more kind of in that severe to impending respiratory failure, imminent airway obstruction kind of phase of croup. So again, next question. An 18-month-old boy presents to ED with 48 hours of coryzal symptoms, so cough, cold, runny nose, all of that. Tonight he wakes up with a barking cough and he's quite short of breath. He is still tolerating oral feeds. On examination, you see this inspiratory stridor at rest with intercostal and subcostal recessions, but the child is alert and he's not tired, he's not lethargic. So he's got a bit of a temperature, his SATs are sitting at 95%, breath rate is 51, blood pressure stable, heart rate 120 also stable. So yeah, so what our next question? So given the likely diagnosis like Croup, what is the most appropriate first step? So feel free to answer your questions in the Q&A tab. Give you a few more minutes. Oh no, a few more seconds. Okay, so the answer is oral dexamethasone, that's correctly. So breaking it down a little bit further, so IV antibiotics you wouldn't really do, we don't tend to do it with Croup. As we saw initially, it's very much a viral infection, so you wouldn't really treat with antibiotics. And in this particular situation, it's not going to do anything. It's not going to, it's not going to help anything at the moment. Stridor is very much an airway issue, given antibiotics isn't going to help at this point. Oral dexamethasone, yes. So we've said that the child has been tolerating oral intake, so we're happy to give oral dexamethasone. Does put us into moderate Croup, but even with moderate Croup, the treatment is oral dexamethasone. Examining the child's throat, this is something that you wouldn't want to do. When there's basically, it will agitate the child further, and it might increase that risk of airway compromise. So you wouldn't want to mess around with their throat, but you wouldn't want to examine their patient's throat. You just leave them as they are, and maybe examine them later on if you're suspecting something else. If you just want to check to see how it is, you might want to examine them later, but it's not going to do much for as a part of your examination, so you wouldn't rush to do that. Nebulized budesonide. So if the child wasn't alert or wasn't feeding well, you'd go for nebulized budesonide. But since he is, you're happy to go with the oral dexamethasone. So there's no formulation of nebulized dexamethasone. That's why it goes from oral dexamethasone and then nebulized budesonide. Yes, and finally, administer oxygen. So yes, there's sign of respiratory distress, but the stats are fine, the 95%, so we don't need to give oxygen. And now, moving on from the same case. So after receiving oral dexamethasone, the stridor has now worsened and he's now head bobbing with that significant tracheal tug. His rest rate has gone up to 70. I think it was 50 initially, and his SATs have gone down to 90% from 95. Which of the following is the most appropriate management option? Okay, so moving on to the answers. The answer is nebulized adrenaline. So with this situation, so let's break down all the answers. So with nebulized salbutamol, we don't tend to do salbutamol in Group management. It has no role. Salbutamol is more to do with chest, kind of lower respiratory help, isn't it, with the bronchodilators? There's no point in giving that at the moment. High flow oxygen. So yes, it is important, because especially because the SATs have now gone below 92%. But remember, use the A to E approach. the first thing that will come up is A, which is airway, and that's what's most important when it comes to croup, because it's all to do with the airway. So whilst high flow oxygen is important, nebulized adrenaline comes first. And in fact, because it's nebulized, you can connect it with the oxygen as well. So it can be driven with oxygen too, so it can be mixed in. But high flow oxygen on its own is not the most important thing yet. So urgent cricothyroidotomy, not a first line management. Even if you wanted to secure an airway, you would intubate, not do cricothyroidotomy. And then nebulized adrenaline. So as we said, this is what we would do because the child has worsened. There's no real point in giving nebulized budesonide because it would basically have the same effect as dexamethasone, and it's not really helped. So what it's time to do is, because we're heading towards the airway obstruction, that stridor has worsened, the respiratory distress has worsened, SATs are lowering, it's time to address the airway because that's where the issue is. And you give nebulized adrenaline, and this is an emergency measure. It gives you temporary relief, and it might help, but if not, it might help for a little bit, and it will at least buy time for intubation. It might buy time for you to, get the anaesthetist, get things ready to intubate. And lastly, IV hydrocortisone, still a steroid, but it doesn't affect the airways. So I think in some trusts you might see IV dexamethasone, and that's more to do with helping stridor, but more not in the initial management of croup, but more with post-extubation kind of situations. So IV, not particularly a role when it comes to croup. Okay, so management. So for mild croup, as we went through, it's oral dexamethasone, and the dose is 0.15 milligrams per kilogram. You're happy to discharge home if they've got mild croup, and there are certain exceptions for when you'd want to admit them. So if they've got hemodynamically significant congenital heart disease, if they're less than 3 months old, and if they've got this inadequate fluid intake because they're not tolerating, whether they've got a sore throat or they're just vomiting it out. So you'd want to keep them in if there are any of these situations. But in general, mild croup, send them home and make sure you give some oral dexamethasone before. Oh, there's more to that one. Yes, and then there's moderate, severe, or impending respiratory failure. Quite similar in the sense of how we're treating. So you're definitely admitting them, oxygen given as needed. You give oral dexamethasone if they're tolerating oral fluids, or if it's like moderate. And so again, same dose, but then if that doesn't work, or if they worsen, or if airway obstruction is imminent as soon as they come in through the doors, you'd go for nebulized adrenaline. But say oral dexamethasone, they spit it out, they're not been tolerating at home, you just go with nebulized budesonide. As we said, nebulized adrenaline is more for that emergency measure. It's not kind of this doesn't work, and this. It's more if they're getting worse in front of you, or you might need it straight off the bat. And then finally, intubation might be the option if they're fatigued or hypoxic. And even if they come in and they're fatigued and hypoxic, then you'd probably just go towards intubation. But of course, those are kind of quite senior-led decisions. So good to know how you're classifying, categorizing them essentially. So complications of croup, you can get airway obstruction. So that's why whilst it's a very common illness, it's something that parents should be aware of, and it's good to kind of educate them when you send them home, because it can get bad, and it can get bad quite quickly. So upper airway inflammation and edema is what can precipitate this acute airway obstruction, and that will require nebulized adrenaline, which might make things better, or it might not, but it will give you a little bit of time whilst you're considering intubation. And then superinfection as well. So croup, it can also get bacterial superinfection, which can result in bacterial tracheitis, which is commonly associated with Staph aureus, a very nasty infection and potentially life-threatening, and can also result in pneumonia. So it can also track down into your lungs. But yeah, those tend to be the common complications. So yeah, that's everything. That's us done for today. Feel free to ask me any questions now. Again, you can ask them in the Q&A tab. That's been working the whole time. And then also, yeah, or if you any other way of asking questions, if you want to email me as well, feel free to do that. I had a few emails which I'm more than happy to reply to too. And yes, if you could please do the feedback form. I think this is my last one of the series at the moment, but I'd be happy to do more if you guys are enjoying it. So please fill the feedback form and we can see what you guys are interested in particular, if you want me to do more pediatric topics. The slides, if you're a biomedicine member, subscriber, then you should be able to access all of the slides. But drop me an email if you're not, and we'll see how we can go about giving you them. Clinical signs of superinfection. I just had that question. So what are the clinical signs of superinfection? With bacterial tracheitis, a lot of similar symptoms, but they tend to be a lot worse. And you might kind of see a lot of white, like pus spots in the throat too, which you'd see more afterwards because you wouldn't be looking to examine their throat anyway. But it just tends to be, it just causes a bit more of a worse croup. I've never seen it myself, but it's essentially similar symptoms, but the child gets more unwell because it's just coming from a much more nasty source of infection. So a lot of times they might need they will need IV antibiotics as well if you're suspecting bacterial tracheitis or bacterial croup, because you'll need to keep them in for IV antibiotics as well, because as we said, it gets quite nasty and they've got that higher risk of airway compromise with bacterial infection. So you definitely admit them and probably do their blood tests, see how their inflammatory markers are, start them on IV antibiotics. Yeah, the signs itself aren't crazy different. They're just a lot more unwell with it. I hope that helps. No worries. So yeah, I'll just leave this slide on for a little bit longer if anybody else wants to ask any questions, or if you want to use the QR code for the feedback form. Yeah, hope you enjoyed it. Have a lovely evening.